Hello everybody. In this part of the respiratory system, I'll talk about the respiratory volumes and capacities. We measure the respiratory volumes and capacities to do the lung function test. That means if someone's lung is healthy or not. So if the volumes and capacities are within the normal ranges, then we'll say that the person's lung function is normal. There are four different volumes we measure, and by adding different volumes we get the capacities. So there are four volumes and four capacities, and by adding different volumes we get the capacities. So we'll see those respiratory volumes and capacities. Then we'll talk about the respiratory rate of breathing per minute. So how many times we breathe in each minute, that's the respiratory rate, and the rate is different in male, female and children. Then we'll talk about the partial pressure of gases. Gas exchange depends on the pressure difference. So this is a rule of gas movement of oxygen and carbon dioxide from high pressure to low pressure. Gas always moves from high pressure area to the low pressure area. Okay, we'll see how the movement of the oxygen and carbon dioxide takes place by the pressure difference. Then we'll talk about the external and internal respiration. External respiration is the exchange of gas inside the lung. What happens inside the lung? You all know that blood goes to get the oxygen from the alveoli of the lung, right? So inside the lung, oxygen goes from the lung to the blood, and carbon dioxide always moves to opposite direction. That means from the blood to the lung, and that's the external respiration. What happens inside the lung, the gas exchange inside the lungs. And internal respiration is between the blood and the tissue. Why blood goes to the tissue? Just think that blood goes to the tissue to give oxygen. Makes sense? So tissue needs oxygen, so blood gives oxygen to the tissue, and carbon dioxide goes from the tissue to the blood. That is the internal respiration. So what happens in the lung? That's the external, and in the tissue, that's the internal respiration. Then we'll talk about oxyhemoglobin saturation curve. The pressure of oxygen and saturation means how much oxygen is taken by the hemoglobin or binding with the hemoglobin. That's the saturation. Okay, so the binding of oxygen with the hemoglobin, that's the saturation. Then we'll talk about the transport of gas by the blood. We know that blood transports the gases, oxygen and carbon dioxide. So we'll talk about that. Then we'll talk about the regulation of breathing or respiration. In your brainstem, pons and medulla oblongata, you have the respiratory centers, and the centers control the breathing. Okay, so we'll see what are those respiratory centers and what they do to regulate the rhythmic breathing. Then we'll talk about few clinical conditions. So what are those four respiratory volumes? The respiratory volumes are tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. So tidal volume is very simple: how much air you inhale or exhale during quiet resting condition. So you are in resting condition, how much air you inhale or take from the outside, and how much same amount you expel, and that volume is about 500 milliliter. Okay, so we inhale 500 milliliter and also exhale 500 milliliter in normal quiet resting condition. That's the tidal volume. Now you have two reserve volumes, right? One is the inspiratory, another is the expiratory. Inspiratory reserve volume is after you inhale normal amount of air. If I ask you to take more after you take the normal amount, that additional volume of air that you can inhale or intake after you finish normal breathing, that additional volume is the inspiratory reserve volume. We can do that, but normally we don't use it. Makes sense? When you use the inspiratory reserve volume, if I ask you to go under water and stay there for a few minutes, then you'll try to take as much as air you can inhale, right? So that additional volume is used during that time. During exercise, you inhale and exhale more, right? So that additional volume is used during exercise. Or also, if I ask you to blow a balloon, then you will first inhale more than normal, and that additional volume you inhale is the inspiratory reserve volume, right? So those are the conditions. Expiratory reserve volume is after you expel normal amount 500 milliliter. If I ask you to expel more air, you can do that, right? So when you blow the balloon, you do that. You first expel 500 milliliter normal amount, then you push more. So by forceful expiration, the additional volume of air that you can expel is the expiratory reserve volume, right? Residual volume, the amount of air left in the lung after maximum exhalation. So if I ask you to push all the air out from your lung, after you do that, still some air will remain inside the lung. You will not be able to expel that amount, and that volume or amount is the residual volume. And residual volume is important because even after you forcefully expel the air out, some air must remain in the lung, because blood is always going to the lung to get the oxygen, right? So if you can expel all the air out, then the blood will go to the lung and come back without getting any oxygen, which is not good, right? So the oxygen level will drop suddenly. That's why this residual volume is very important. It remains in the lung even after you forcefully expire the air out. Now, as I told you, the capacities, there are four capacities, and we get by adding two or more volumes. So inspiratory capacity is the amount or volume that we get by adding tidal volume and inspiratory reserve volume. So these two, tidal and inspiratory reserve. Vital capacity we get by adding these three: expiratory reserve volume, tidal volume, and inspiratory reserve volume. So two reserve volumes and the tidal volume. Make sense? And the functional residual capacity is the volume we get by adding expiratory reserve volume and residual volume, by adding these two. And total lung capacity is the volume we get by adding all those four volumes. Vital capacity, you see here, vital capacity means these three volumes and the residual volume, right? So 3 plus 1, all four volumes together give the total lung capacity. Okay, and we calculate these volumes and capacities to determine the lung function. Here you see the normal 500 milliliter tidal volume in normal quiet resting condition. We inhale and exhale. So this way is, you see the volume, this is the volume remains in the lung this way. Okay, and this is how much we exhale and inhale. Okay, now this one, you see inspiratory reserve volume here, inspiratory reserve volume, the volume you can inhale after normal. So from here to here, how much you can take by forceful inhalation. So this is normal inhalation 500, and here normal ends, then you take forcefully this additional volume here. Okay, and expiratory reserve volume is this amount. You see, you can expel after normal expiration. This is normal expiration, you expel 500 milliliter, then after normal, if you exhale more air, then the volume inside the lung goes down. So this way, if it goes this way, that means inside the lung the volume of air is going down. This way, the inside the lung the volume is going up. Make sense? So after inspiration going this way, after expiration going this way. Okay, here you see the differences of those volumes and capacities between the male and female. Male body is more muscular, respiratory muscles are stronger, and the total size of the body is bigger, and also the metabolism is more in male body than the female body, right? So metabolism more means male body requires more oxygen, because oxygen is used in metabolism. And also the muscles are stronger, so the respiratory muscles are stronger in male than the female. So the volume and capacity, those are bigger in male. Respiratory rate, in each minute how many times you breathe, that's the respiratory rate. And in normal resting condition, adult person, the range is 12 to 18 times per minute. So that's the normal adult resting condition, of course not during the exercise or when you are excited. Average children, the rate is higher. Okay, in children's body the metabolism occurs more, and that requires more oxygen. Okay, partial pressure and gas diffusion. As I mentioned, the rule is gas always moves from high pressure to the low pressure. Okay, so that is very important to know. So the oxygen and carbon dioxide both move from the high pressure zone or area to the low pressure zone. So now if you see inside the lung you have the alveoli. Each lung has about 1 million alveoli. So this is one alveolus, and if you see the pressure of oxygen inside the alveolus is about 100 millimeter of mercury, and the blood that flows inside the capillary, and this capillary bed is on the alveolus. You remember each alveolus has capillary bed on its surface. So you have the blood here inside the capillary, right? So this is the capillary and this is the alveolus. Now we know that blood goes to the lung to get the oxygen, right? Deoxygenated blood goes to the lung. So this blood arrives in the lung is deoxygenated blood. So it has less oxygen, and the pressure of oxygen is 40 millimeter of mercury. So when the blood enters into the lung, the pressure of O2 is 40 millimeter of mercury only. But inside the alveolus of the lung, the pressure of O2 is 100 millimeter of mercury. So you see the difference is 60, right? And that 60 millimeter pressure difference will move O2 from the alveolus to the blood. So now blood is getting the oxygen, right? And becomes oxygenated blood. So oxygenated blood will go to the heart, right? And then heart will send it to the body, to the tissue. Now, I told you that carbon dioxide always moves to the opposite direction. That means carbon dioxide will go from the blood to the alveolus. So the pressure of CO2 should be high inside the blood, right? So CO2 pressure is about 45 millimeter of mercury in the blood, and inside the alveolus it is only 40. So difference is 5 millimeter, 45 and 40, right? So CO2 will move from the blood to the alveolus. So oxygen will enter into the blood and carbon dioxide will leave the blood, and that exchange inside the lung is called the external respiration. External respiration that I mentioned earlier, what happens in the lung, right? Now the oxygenated blood will leave the lung and will go to the heart, and heart left ventricle will pump the blood and send it to the body. When the blood will take the oxygen to the body, in your tissue what will happen, this is the tissue collection of cells, and the blood now brings the oxygen here, right, to the into the tissue, and now blood will give the O2 to the tissue. So the pressure of oxygen is high here, and in the tissue it is low. So the oxygen will move from the blood to the tissue. Tissue needs oxygen, right? Blood goes to the tissue to give the oxygen, and blood goes to the lung to get the oxygen. So that's the important information. So O2 will get out from the blood to enter into the tissue, and you already know that CO2 moves to the opposite direction. So from the tissue, CO2 will enter into the blood, and here CO2 pressure is 45, in the blood 40. So 5 millimeter pressure difference will move CO2 from the tissue to the blood. So remember, blood goes to the lung to get the oxygen. So blood will receive the oxygen, and blood goes to the body or tissue to give the oxygen. Make sense? And carbon dioxide always moves to the opposite direction. Okay. Now the question is, here you see 60 millimeter pressure difference of O2 moves the oxygen, right? And 5 millimeter pressure difference of carbon dioxide moves the carbon dioxide from one place to another. Why you need less pressure to move the carbon dioxide but more pressure to move the oxygen? The reason is carbon dioxide is more permeable through the living membrane. So small pressure difference will move the carbon dioxide more easily. Make sense? So here you see external respiration, that means in the lung. So deoxygenated blood entering into the lung, and this is the alveolus. So blood gets the oxygen from the alveolus, and the pressure difference is 40 millimeter. You see O2 pressure is 40 here when it enters into the lung, and in the alveolus 100. So 60 difference, right, will move O2. And here the pressure of CO2 when it enters is 45, but inside the alveolus 40 that I mentioned. So 5 millimeter pressure difference will move the carbon dioxide. So that's the external respiration. And now we'll see the internal respiration. Blood goes to the heart, and from the heart left ventricle pumps the blood, and that blood goes to the body, to the tissue. Now something interesting you see here. When blood left the lung, the pressure of O2 was 100 millimeter of mercury. That means high oxygen saturation. But this blood goes to the heart, and then heart sends to the body, to the tissue. And when the blood moves towards the tissue, what happens, in some places in your body there are arteriovenous anastomosis. What is that? This is an artery and this is a vein, and in some places arteries and veins are connected by short vessels. This is called anastomosis. So you see, vein has deoxygenated blood, right, and artery has oxygenated blood. Here you have 100 millimeter oxygen pressure very high. But when the venous blood is small amount enters into the artery, that mixing of venous blood will reduce the oxygen concentration slightly. That's why when the blood will arrive in the tissue, its pressure goes down a little bit. How much? About 5 millimeter less. So for 95 millimeter of mercury O2 pressure when it goes to the tissue. But which is fine, because in the tissue you see O2 pressure is only 40. So the difference is here 55 millimeter of mercury, right? This one and this one. So oxygen will get out because of that 55 millimeter pressure difference. And carbon dioxide, as I mentioned, 45 in the tissue and 40 in the blood. So from 45 to 40, CO2 will move. So blood will become deoxygenated because it is losing O2 but getting CO2. Makes sense? And this deoxygenated blood will go to the heart, and heart will send it again to the lung to get the oxygen. Makes sense? Okay. Transport of blood. How the blood is transported? Blood is transported. We know that blood transports the gases, oxygen and carbon dioxide. So how blood transports O2? About 98.5% O2 or oxygen is transported by the hemoglobin. And in the hemoglobin you have heme. You remember that heme has iron, right? Fe plus plus, and oxygen binds with that iron of heme, and 98.5% O2 is transported by the hemoglobin, the heme of the hemoglobin, and only 1.5% transported by the plasma, dissolved, gets dissolved in the plasma. So mainly by the hemoglobin. And when oxygen binds with hemoglobin, that hemoglobin is called oxyhemoglobin, HbO2. It looks bright red. This is a hemoglobin structure. So you can see this is heme, this is iron, and O2 binds with this. Oxyhemoglobin saturation curve is an S-shaped curve like this, and this curve shows the pressure of oxygen this way and the binding this way. So we'll see that curve. You see, this is the oxyhemoglobin saturation curve, and pressure of O2, PO2, pressure of oxygen in millimeter of mercury is this way, and saturation, percent saturation is showing this way. So when the hemoglobin is empty, it will quickly bind with the oxygen. Makes sense? So you see the first part of the curve is very sharp rise, because the pressure of oxygen here is going up, right? And the hemoglobin is getting saturated by the oxygen. That means oxygen is quickly getting attached to the hemoglobin because hemoglobin is empty. With small pressure increase, the oxygen will quickly bind with those empty hemoglobin. Now when hemoglobin will get more and more saturated, then even if you increase the pressure a lot, the binding will be less. That's why you see kind of flat here, no more sharp rise. So that's the oxyhemoglobin saturation curve, and conditions can change the binding or saturation. One is the pH of blood. If pH is low, that means acidic, the saturation will be less. If the temperature is more, saturation will be less. And also 2,3-biphosphogyl BPG is another factor. Increased BPG leads to hemoglobin releasing more oxygen. That means the hemoglobin will release oxygen easily. Here you see the normal curve. This is 7.4 pH of blood is the normal pH, and if the pH goes down, the saturation will be less. This way saturation is more. So if the curve moves this way, saturation is more. If the curve moves this way, saturation is less. Okay, so pH low means acidic will decrease the saturation. pH high will increase the saturation. Here you see temperature, increased temperature. This is normal body temperature. Increased body temperature will decrease saturation. Okay, and in cold body temperature the saturation will be more. So those are the factors that changes the binding of oxygen and hemoglobin, as well as the release of hemoglobin is changed by those factors. How the carbon dioxide is transported? Carbon dioxide is mainly transported as bicarbonate. So as bicarbonate, HCO3. About 70% carbon dioxide will be transported as bicarbonate. You see carbon dioxide is here, right? And 23% will be transported by hemoglobin. And when carbon dioxide binds with hemoglobin, that is called carbaminohemoglobin. Okay, 23%. But remember, 98.5% O2 is transported by hemoglobin, but only 23% CO2 is transported by hemoglobin, and about 7% CO2 is transported by the plasma, gets dissolved with plasma and transported by the plasma. Okay, how carbon dioxide is transported as bicarbonate? You see, when carbon dioxide gets mixed with water, what happens? A reaction takes place, and that will produce H2CO3 carbonic acid, and it will quickly split because an enzyme that is called carbonic anhydrase or Ca, that will split it into H and HCO3. Makes sense? So this is positive hydrogen and HCO3, and the carbon dioxide is here, right? So this is the form how the carbon dioxide 70% will be transported. Then when carbon dioxide should be released, just opposite reaction will occur. These two will join together to form this, and then this will break into CO2 and water. So just opposite way the reaction will occur to release the carbon dioxide. So to transport will go this way, to release will go this way. Okay, so in these pictures you can see how the carbon dioxide is transported. We know that 23% with hemoglobin and 70% as bicarbonate, and small amount 7% by the plasma. So plasma is here. This is the red blood cell, right? This is the red blood cell. And when the hemoglobin transport takes place, 98.5% hemoglobin oxygen is transported by the hemoglobin. Okay, by hemoglobin, and that's the main form how the oxygen is transported. Okay, and a small amount is dissolved in plasma, only 1.5%. Okay, so that's how the gases are transported. Okay, now we'll talk about a few clinical conditions. Compliance of the lungs. It's the ability of your lung to expand. If the elasticity of your lung is more, that means your lung is healthy and the expansion will be more, right? So the ability of your lung to expand is the compliance. Okay, and the condition of your lung tissue that is a big factor that determines the compliance. If the lung tissue is highly elastic, that means healthy, compliance will be more. If the lung tissue deteriorates, if someone smokes for many years, like chronic smokers, the lung tissue will gradually lose its elasticity, so the compliance will be less. Make sense? So that's the important thing. Chronic obstructive pulmonary disease, COPD, we commonly hear that. This actually includes a number of clinical conditions. Three common examples of COPD are asthma, chronic bronchitis, and emphysema. Asthma is a condition in which the bronchioles constrict due to allergic reaction mainly, and allergic reaction releases some chemicals that cause the constriction of the bronchioles. Okay, and different people get asthma by different factors or things. Someone has cold allergic reaction, someone has allergic reaction to pollen, someone has allergic reaction to certain food, right? Someone has reaction to mold. So different people have different sensitivity and allergic reactions, but the common thing is that the chemicals that will be released in the body will cause the constriction of the bronchioles. Okay, and that will cause the secretion of mucus. Okay, and the constriction of the bronchioles and secretion of mucus will block the passage of air, so that person will have distress breathing. Bronchitis is could be acute and chronic. Chronic bronchitis usually occurs to the people who smokes, like chronic smokers. They get chronic bronchitis and it may last for many years or even throughout the life. And in bronchitis, the secretion of mucus blocks or clogs the airway. Okay, so the resistance will be high and the sputum production increased, and that causes the problem, breathing problem. Emphysema, alveoli, and if the wall of the alveoli are destroyed, then the total surface area of gas exchange goes down, right? So that is the emphysema. So destruction of the alveolar wall. Okay, total surface area of gas exchange decreases, and some chemicals can do that. Smoking can also cause emphysema, so there are many factors. Now the last thing is the regulation of respiration. I mentioned that in your brainstem, that means in the pons and medulla, you have the respiratory centers, right? So you see the medulla oblongata and pons, and these are the respiratory centers. Three centers are very important. Let me mention here. So this is the pons and this is the medulla, and in your pons you have the pontine respiratory center. This is the pontine, and in your medulla you have two groups: ventral, this is the front ventral respiratory group, and this is the dorsal respiratory group. Okay, so these centers regulate your normal rhythmic breathing. Okay, so when you start to inhale the air, you see this is the lung, and the diaphragm is here and intercostal muscles, right, between the ribs. And when the diaphragm moves down, the expansion, vertical expansion occurs, and when the intercostal, at the same time intercostal muscles contract, they will move this way, will expand the lung this way, right? So the expansion of the lung will occur, and when the lung is expanding, there are receptors in the muscles, in the covering of the lung, also in the lung tissue. All these receptors will send signal to the dorsal respiratory group. So from the receptors present in the lung wall or the covering of the lung or the muscles will send signal to the dorsal respiratory group in the medulla, and the dorsal respiratory group will collect that information. And when the dorsal respiratory group will think that lung has expanded a lot, now it should be stopped, it will send signal to the ventral, and ventral will send signal to the muscles and diaphragm, intercostal muscles and diaphragm, and tell them to stop. Okay, so the signal is first collected by the dorsal, that how much expansion has taken place, and these receptors are stretch receptors. That means stretching, how much stretching is occurring in the lung tissue or in the muscles, that would activate the receptors. Okay, and ventral will stop, and then after the ventral stops the muscles, then muscles will relax, right, will not contract anymore, will relax, and the lung will go back to its actual shape. That means will squeeze and go back to its actual shape. So that will cause the expiration, right? So lung will get smaller and air will get out. Again, the lung will start to expand by the contraction of the muscles, and dorsal will collect the signal, and at one point will tell the ventral that lung has expanded enough, now time to stop. So the ventral will send signal to the muscles to stop. So that's how the rhythmic breathing takes place without our knowledge, without our will. It's happening even when you are sleeping. So it is autonomic control, right? And Pontine is actually the boss sitting in the pons and watching or monitoring the activities of ventral and dorsal, and if any fine adjustment is needed, then it will send signal to the ventral or dorsal to fix that issue or problem. Okay. Groups of neurons that regulate your normal rhythmic breathing. Okay, so just go over your textbook so you'll understand better. So these are involuntary, that means autonomic, right? Even when you are sleeping, rhythmic breathing is taking place. Now, in the cerebral cortex, limbic system and hypothalamus, you have some centers, and you know your rhythmic breathing you can stop. If I tell you stop your breathing now, you can do that, right? That is voluntary. You can voluntarily change the breathing or stop the breathing. So that is controlled by the higher centers. Okay, so the cerebral cortex has the centers that will send signal to change the breathing voluntarily. But if you don't wish that, normally rhythmic breathing will take place. Lower centers in the brainstem control the autonomic or involuntary rhythmic breathing, and the cerebral cortex controls the voluntary respiration. Couple other clinical conditions, let me talk about those. This is the lung, and you know that the covering of the lung is called the pleura, right? It has two layers, outer parietal and inner visceral. Pleurisy or pleuritis is the clinical condition that indicates the inflammation of the pleura, and when inflammation of the pleura, these layers occur, then the chance of friction between these two layers increases, and if these two layers are inflamed, then when the lung contracts and expands, what happens, these two layers move to opposite directions and they rub each other, and that causes sharp pain. So pleuritis is the inflammation of pleura, and that can cause friction between the two layers of pleura and cause pain. You remember that in the pleural space the pressure is 756 millimeter of mercury, right? and here is 760 millimeter of mercury. So the pressure is always less in the pleural space than inside the lung, and that helps to keep the lung expanded. If the pressure around the lung is higher, then the lung will squeeze. That's why it is important that around the lung in the pleural space the pressure is less than inside the lung, and this is the interpleural pressure. If someone gets injury in the pleura, then what happens? For example, if someone gets stabbed by a knife, so that will pierce the pleura, right? And since outside of the body the pressure is 760 millimeter of mercury and here is 756, the air will quickly get into this space, and that will increase the pressure here and will cause the lung to squeeze, and that is called pneumothorax, air in the chest. Pneumothorax. Okay, so this is a clinical condition and that happens in case of injury to the pleura. Okay.